Scientifically speaking, we're sharing the view. From labs to clinics, breakthrough shining through, with minds that inspire and stories to unfold. Scientifically speaking, the future's being told.
Welcome to another episode of Scientifically Speaking with Christine on Oz Arab Media. Today, we're exploring a topic that has come sharply into focus across Australia in recent years, which is the rise of autoimmune diseases, particularly those affecting the brain and the nervous system. Well, from multiple sclerosis to rheumatoid arthritis and other neurological associated diseases, doctors are seeing significant shifts in how often these conditions appear and how they present. Joining us today is Dr. Serge Geara, a consultant neurologist whose work spans neuroimmunology, neurogenetics, mitochondrial medicine, and complex immune-related neurological disorders. He speaks 5 languages, works closely with multicultural communities, and is recognized for combining clinical practice with cutting-edge research. Dr. Serge, welcome to the show.
Thank you for the introduction. I appreciate it. I just like to think of myself as a person who just goes after knowledge. So I find it weird when they talk about my specialties, but yes, thank you.
Well, that's what you do, and that's what you're special for, and we need to recognize those and appreciate them. So welcome again to the show. And if you don't mind me, let me start straight away with our topic today, which is the autoimmune disease. When people hear autoimmune disease, they often think of vague symptoms or general inflammation. But how do you, from your expertise, really define autoimmune disease in simple terms?
Yeah, definitely. And obviously, I think this space has been hijacked a lot by wellness, by online influencers, etc. So inflammation, in a general term, is actually a very protective function. Inflammation is what happens to us when our immune system perceives a threat, and that causes the immune system to activate in a certain way. And there are certain cascades that happen depending on what's happening next step, and that's inflammation. Now, autoimmune diseases is in the word. Auto means self, and immune means involving the immune system, is a specific subtype of inflammation in which the body can attack itself or act in such a way to perceive otherwise a non-important threat as an important threat, and that can cause immune disorders. This is a very broad subcategory and can include things that affect the whole body system or just the skin or just one organ. And it can be very mild or it can be very severe. And we've just started understanding these ideas recently, much more. Previously, it was just thought that when somebody has a transplant, that the body attacks the rest and you can have rejection. But now we think of a lot more risk factors and things like that. And we understand more subgroups of autoimmune disease.
Right, that is very interesting. Now, you specialize in neuroimmunology, which is the immune condition that affects the brain, spinal cord, and nerves. Now, from a personal perspective, what drew you personally into this field?
So when I was in medical school, initially I did psychology in undergrad, and I was really interested in the interaction between, at American University of Beirut. I was really interested in the interaction between what happens in your body and what happens in your brain, which I know sounds not very complex, but I was hoping more to have a mechanistic explanation for why people get depressed, why people get schizophrenia, because at the moment we have theories, but we're not really sure about these correlations as much as we should. And then entering into med school, there was the big story in New York Times about Brain on Fire, who was a lady who was misdiagnosed, was felt to be making up her symptoms and things like that, and turned out to have chronic autoimmune encephalitis. So her brain was being attacked by herself and was getting
Oh.
inflamed, and she was getting seizures and things like that. And she wrote her journey because she was a journalist, and that made autoimmune encephalitis more in the forefront. So I
Wow.
got into it because of a specific field called psychoneuroimmunology, in which your behavior is affected by the inflammatory system, which then affects also your brain structures and things like that. So this is very niche, but obviously pulling back, I then developed more interest into other structures in the brain and more common diseases such as multiple sclerosis, sarcoidosis, and all. And we now understand in the last 10 to 15 years, multiple sclerosis specifically, but all autoimmune neurological diseases and muscle diseases much more, which has made it even more exciting because now we can treat patients in a much more specific way.
Amazing. I am looking forward to hopefully be able to talk about some of those cases today. And it's very interesting to see how your first major was linked with your second major, and now it comes with a neuroautoimmune. So let's try to dig in today. So an autoimmune disease can affect people of all ages and backgrounds. Please correct me if not. But from your clinical experience, what's the most common misconception that people have about these conditions?
I think a couple of things. Yes, autoimmune diseases, if we talk at autoimmune diseases in general, they tend to affect young females. And when I say young, between the age of 25 to 45. However,
Okay.
specific neuroimmunological diseases can have different, either be male predominant, female predominant, childhood predominant, adult predominant. And the other big thing is the fact that there's actually diseases that before we thought, oh, it's just dementia or just an infection in an old person, and they end up being immune.
Oh.
When entering a neurological case in general, my philosophy is have an open mind. So, sorry, again, what was the question specifically? So, the
Yes. So
age
what's the
specifically
most
or
common misconception people have about autoimmune?
misconception? Yeah.
Yeah.
That's right. So autoimmune diseases, people think that it's always the body attacking oneself, but it can be some diseases in which the immune system turns off a place or turns on. It's not only an on-off button. It's more of a trying to balance multiple. Let's say you have a pizza. Think of the immune system as a pizza, and you're trying
Okay.
to cut it in different ways so that every part of the body has a specific exposure and specific protection against infections or other things. But there
Right.
could be a situation in which that balance, where you cut the pizza in a way and you get more of one piece towards one area in the immune system. So it's not just on off. So people think, okay, well, why don't we just turn off the immune system and things will go well?
Yeah.
But we have to think which part of the immune system to turn off. And the
It's like,
second thing I think is there's a lot of online pop medicine that is like control your inflammation. And I
mm,
think you can't just control your inflammation most of the time. I think obviously there's a lot of good things you can do preventatively, but there's a lot that's already written in your DNA and in your exposures and the environment that you really can't do much about. So I guess giving people grace, eat healthy, sleep well, avoid stress, as we might talk about later.
right.
But there is a lot that's already in your genes, and you know that it's gonna like there's a higher risk of it happening as a result. So that sort of whole sub part of people saying you can control your inflammation. Inflammation is such a big word, and therefore control autoimmune diseases, I think, is a big misconception in the field of neuroimmunology.
Right. Yeah. I'm hoping to dig in more as well, because I want to know if it's all preventative or it's all completely medical, that, it can happen to you without even you doing everything right, and then it can still happen to you. Is that a case?
I think it's a bit of both. So
Mm.
what I would say is, so for example, there's certain ethnic groups that are more at risk of certain immune diseases, for example, and that's
Okay.
not strictly a neuroimmunological disease, but can affect the immunology. There's a disease called familial Mediterranean fever, where people get
Okay.
fevers that are not explained. and they happen, and then you give them a treatment, and it goes away. And this
Mm.
is obviously a bit more complex than that. This will most likely happen in people who are of Mediterranean background, as the name suggests, and including people who are Lebanese, people of our communities, etc.
Oh.
And multiple sclerosis, although it happens in a lot of places, it tends to happen in places where there's less, where you're most away from the equator, and it tends to correlate with decreased exposure to sun. So there
Mm.
are risk factors and there are things that are already determined. However,
Mm.
in the same token, there's a lot of things that you can do to modify your risk. So think of it as sort of how the building is already built. There's a fire alarm. The fire alarm is how you set it to decrease the risk of detecting a fire if there's there, but the building is already built and you already are come with your own risk, sort of
I agree.
risk
Okay.
levels and things like that. Yeah.
That does make sense a little bit. Now, symptoms can often be subtle or easily confused. So, with other health issues, maybe. What early signs should people and families be paying attention to from your expertise?
Yeah, so the thing with immune disorders is they actually, or specifically neuroimmune disorders, they can affect a lot of places in the immune system. And yes, they can be subtle or really bad. So, for example, there is a syndrome called Guillain-Barré syndrome, which happens usually after a gastroenterological infection, but it can happen after a lot of other infections, where the immune
Mm.
system still thinks it's fighting infection, but it's not. It's fighting your nerves, but it specifically
Mm.
fights the nerves in the body which control your reflexes and sometimes your sensation, sometimes your power. So this the spectrum of that is anywhere between people who get a bit of numbness and tingling in your fingers and toes to if it affects the nerves that are around your brainstem to you being in a coma. So it's a very big spectrum.
Wow.
And I guess it's very hard to say what to monitor for in terms of symptoms, but I'll talk about some classical things. If your visual acuity, if your ability to see color and vision it decreases very quickly over 7 days or 2 weeks
Okay.
without any clear redness or anything like that, then that could be optic neuritis, inflammation of the optic nerve,
Okay.
which is associated with a lot of neurological disorders. Um, Confusion and brain fog, which again happens very quickly and out of order. If you keep getting seizures, one seizure can happen in up to 50% of people in the society, but most
Mm.
people don't get a seizure again. Sorry, up to 10% of people, but
Yeah.
half of these people will never have a seizure again. But if you keep having seizures despite medications, um, brain fog, change in behavior, which is unexplained by risk factors. So if you have a family history of other psychiatric disorders, it becomes probably familial. But if it's
Mhm.
not, then acute change can sometimes warrant investigation. And in the nerves and muscles, you can have muscle weakness or numbness or tingling or other changes. The thing is there's other disorders that can give you all these symptoms. But I think immune disorders have a we talk about the tempo. So
Yeah.
stroke can happen quickly. Chronic disorders take years. Immune disorders are days to weeks. So the
Mm.
development of these symptoms over days to weeks usually points towards a neuroimmunological disorder because this is how quickly the immune system works usually to attack things and things like that.
Interesting. So that's really what we should be looking for. In the last few years, Dr. Serge, Australia has been growing numbers of cases of autoimmune neurological diseases. So, what trends are you noticing in your clinics and hospitals today?
Definitely increasing. I think there's a few reasons for that, and there's always the debate in any disease
Mm.
that increases in incidence. Basically, we know now how to identify this neurological disorders much better than we did before. We have many more blood tests, lumbar puncture tests, and better MRIs, and we know more what the MRIs mean in the last 50 years than they did before. So we
Right.
have the ability to diagnose as a result of that. We also have better medications, so there's more motivation to treat people.
Yeah.
Definitely, the trends are towards an increase. However, I think, and that's controversial, and that's always in every disease that increases, there's this, like, what is increasing this? And there's a feeling that there's something environmental that is
Mm.
increasing our risk of that. There has, and even something environmental such as um, being stressed and not talking about it. So there was a recent paper in Neurology Journal that talks about women who get stressed and don't talk about it. And that they found that they, obviously it's a correlation study, but they have an 8 time higher risk of
Oh.
immunological disorder than women who don't, who actually speak their opinions and things like that.
Mm.
So obviously, there's, going back to this situation, there's an interaction between your behavior, your lifestyle, but also the background risk factor, and we have a better a way of detection. And also, the second thing, I guess, is we are also taking more symptoms seriously in males because, like we said before, a lot of these symptoms before were felt to be related to in females, but now
Yeah.
we think that, we have to look in
Now,
everybody. There are certain syndromes that happen later in life, syndromes, autoimmune syndromes that happen that are related to cancer,
mm,
that we then start looking for the cancer after treating the immune disease. So, we are now more aware and more available to be able to find out what is happening, um, because of our higher limit of detection. But I do believe that we are increasing in our exposure as well to things, to immune disorder.
right. So we can say that being proactive is the way to go nowadays, rather than just, be stressed
Definitely.
and be sitting in the corner and not talking about it, and, be proactive. It can hopefully, take you to better ways.
Yeah, I mean, there's a big discussion these days about freedom of speech. I think it's very important to do that. I
Amazing.
think, as a person on a personal level, but
Mm.
also in terms of being proactive, I guess, things to take care of your health is unprocessed foods. Processed foods not been associated with immune disorders as far as I know, but they have been associated with dementia. And there's a lot of neurological health that comes from eating healthy, unprocessed foods. So fruits, veggies, Mediterranean diet, olive oil, all this stuff. And
Love it.
also, which the society is doing a good job, but vaping becomes part of this as well, is not smoking. So smoking
Mm.
increases the risk of immune diseases, especially MS. But if you have an immune disease such as MS and you smoke, it becomes worse. So
Worse,
because it's
definitely.
an immune regulator in a bad way. So yeah.
Right. Which autoimmune conditions do you think are currently the most common or trending, if I can say, in Australia?
Yeah, I mean, multiple sclerosis is classically the most common autoimmune disease, but I think, I just want to make a comment about that. So it's prevalence. So if you look at the society, there's about 4 in 1,000 people that have it. However, incidence, so every year we diagnose 1 in 1,000 people with it, and its prevalence is going to increase because now we're treating it much better, and as a result, people are going to live longer and live longer with less complications. In fact, we think that the people who are right now get diagnosed with MS will probably live as much as people without MS. They'll probably have a bit of side effects like infections and things like that, but they will probably live that much. So MS is the most common. And that
Right.
being said, despite the fact that it's the most common, I think that clinicians and neurologists need to know all immune diseases, or a big portion of them, because they can sometimes look like each other. And
Mm.
the response to different types of treatments is different in different immune diseases. So
Mm.
I think, despite the fact that one is common, the others are not uncommon, that we need to always think about the other
Yeah,
ones.
definitely. But what we're mainly seeing in Australia is MS, we can say. Now, many Australians know someone with rheumatoid arthritis, but few
Hmm.
understand that it's an autoimmune disease. So, what makes rheumatoid arthritis different from general joint pain or osteoarthritis?
Yeah, so this is not necessarily in the realm of neurology per se. However,
Right.
it can get to that. Rheumatoid arthritis is a joint inflammation syndrome, which affects specifically not the joint itself, the bone, but the synovium. So places around it that provide lubrication in the joint,
Okay.
right? Usually, joint pain tends to go away and tends to have things that make it less likely to be inflammatory, we say, or
Mm.
immune. Immune um, action usually happens at night. So when you are waking up in the morning is when you have the worst joint pain. The second thing
Mm.
about rheumatoid arthritis specifically is the joints it affects. So usually it affects what they call proximal joints, or closer. So in the fingers, the joints here in the fingers, the elbows get affected, sometimes the shoulders and the neck, but not the distal ones, and not
Mm.
the far one, and not the far one in the thumb.
Right.
So the distribution of the joints is very important. And the other
Mm.
thing about rheumatoid arthritis is not only a joint disorder, it can affect other things because it's one part of the immune system which tends to come here, but can come in different places. So
Mm.
rheumatoid arthritis patients can get problems with liver, with lung, with mentioned the C spine. Sometimes they can get inflammation around the heart. So the syndrome is much bigger than just joints
Right.
symptoms.
Yeah. Right.
Osteoarthritis, on the other hand, is the degeneration of joints after much use and weak joints with time that tends to happen, which can sometimes show on imaging, but sometimes not. And this occurs in weight-bearing joints, so joints that take a lot of weight bearing. And in people, it could be different. Some people have hip, joint, ankle, joint, and hip, knee, ankle. Knee is more than hip. Knee and hip are more than ankle. And the distal parts, where if like people work a lot with their hands, the distal
Yeah.
parts, the far parts, get affected more. And that's treated completely differently. It's not an
But
immune
is it
problem per
considered an
se.
autoimmune
It,
disease? Osteoarthritis?
no,
No. Yeah, that's my, yeah.
osteoarthritis is more of a wear and tear. We don't know why the joints degenerate in the way that they do. And
Right.
its itis makes people think that it's inflammation, but it's actually not inflammation. Like there is
Right.
inflammation there, but it's not an autoimmune disease in that your body is attacking itself. It's just that because of certain reasons we know, which is a lot
Yeah.
of using a certain joint, obesity, smoking, and
Mm.
not having the right diet and things like that can affect things. But also, there's certain reasons we don't know why the joint breaks down and becomes painful and causes different issues.
Right. Right. Okay, that makes sense now. Going back to rheumatoid arthritis in particular, it can be invisible, sorry, in its early stages. So how does the lack of visibility of symptoms really affect how families, or even like yourselves, workplaces, treat someone living with arthritis, rheumatoid arthritis?
Yeah, I think it's a tricky disorder because in a lot of things, again, I'm not a rheumatologist, I'm not a
Yeah,
joint doctor,
yeah.
but I come across patients with rheumatoid arthritis. And it's tricky because uh, sometimes a person can have a positive blood test but no symptoms, or some symptoms and no positive blood tests. And in both times, it can be called rheumatoid arthritis.
Oh,
Now, the situation with this is to, I think, have a good clinician that can weigh the tests, the investigations, and put them together to give the patient a best idea. I think it's very important for the patient to be their own advocate. And it's very important for doctors to not dismiss patients. And I see
mm,
this rampant, and I sometimes hold myself back because the Lebanese community is very famous around non-Lebanese people for having something called waja syndrome, which means
yeah.
that we do not know how to describe our own pain. So we say everywhere hurts.
Everything hurts.
It's
Yeah.
very hard. Everything hurts. So it's very hard to actually help a doctor when this happens, and this causes doctors to also um judge the patients as a result. So it's a two-way street. So I think in patients with undifferentiated symptoms or early symptoms, it's very important Patients should know how to describe it themselves, be their own advocates. Doctors should listen and ask a lot of questions and try to hone it down. And there shouldn't be
Right.
judgment from both sides. If you have the diagnosis, yeah, do the right things and don't blame yourself, even if it's something that you did that caused it. But in rheumatoid arthritis, it usually isn't.
Mm.
And if and always try to communicate the right thing to the family members around you, that despite the fact that you can't see any swollen joints, I'm in a lot of pain right now, and I would like you to understand what's happening. Sorry, this was a lot of points together, but this is
No,
the
of
problem
course.
with
It's
invisibility, that
really
it's very
great to just
complex
tell
as a
our
result.
community, what's happening and how things are happening, so that, they just be proactive themselves and come to people like you when it's the right time, or they think they have the right symptoms for it. So we really thank your elaboration, nothing at all. If you don't mind me just jumping into multiple sclerosis, which is the most trending at the moment, what early signs should people be aware of, especially the ones that are often getting ignored or mistaken for stress or fatigue or the waja syndrome, like you mentioned earlier?
Yeah. All right. So multiple sclerosis, again, like I mentioned before, like all autoimmune diseases, has a lot of big symptoms that can affect a lot of places in the brain. However, in the brain specifically and the spinal cord, it affects areas where there is where it's called the white matter of the brain. So not the top matter where the brain is at the top, but in under it, and that has specific effect in terms of symptoms. So eye inflammation, like I mentioned before, balance issues, the cerebellum gets affected. Sometimes people get depression and anxiety that is unexplained, but can sometimes be seen on imaging and affecting the circuitry of depression. There's a
Wow.
lot of things that happen. So people can get muscle twitching and facial pain called trigeminal neuralgia, or French name for it is tic douloureux. And this tends to sometimes happen before MS. So that can sometimes trigger people to have MS as well.
Mm.
Low vitamin D is associated but not causative with MS. And sometimes people can have a what's called a myelopathy. So a problem in the inside the spinal cord. So people get high reflexes, weakness in the distribution of that spinal cord area that can affect things. And finally, if, for example, sometimes mild symptoms that can happen inside the spinal cord is giving an otherwise young, healthy lady a lot of urinary tract infections, excuse me, urinary
Yeah.
tract infections or bladder issues such as incomplete emptying and things like that. So MS
Yeah.
as a syndrome can have a lot of different ways, but I guess having that suspicion and knowing these symptoms can be helpful to help present to a doctor and try to investigate it and figure out what's happening.
Right. While you're talking about the spinal cord being big part of the MS, do you think the back pain in general can also be a symptom or a trigger that might be MS?
Yeah, so there are a few pain syndromes that can affect things. So, like I mentioned, tic douloureux is
Yeah.
one. So that's as part of the spinal cord syndrome, you get sensation changes, which can give you numbness and tingling
Oh,
and some
okay.
pain.
Wow.
But there's also something called the MS hug. So you feel pain around your chest band, and that's sometimes people describe that. So pain is part of the syndrome, and definitely when we see people in our clinics who have MS or have a suspected immune disorder in general, pain is one of the things we have to address as a symptom, not as part of the syndrome, because
Right.
this can happen sometimes from your brain or spinal cord, not necessarily from the nerve itself or from injury or anything like that.
Right. Now, patients with multiple sclerosis really sometimes carry a lot of fear and misconception. What are the biggest myths
Hmm.
you heard from patients who have been just receiving the diagnosis of MS?
Um, I think the fear is always that, you're usually these people are young, healthy, educated people. So there's a lot of fear around, am I going to be crippled? And surely in the past, people would lose a lot of big, quick power over time. Mainly because the medications we used to have used to slow down the disease but not stop it. And I think now the disease is much better under control in terms of if you get diagnosed and you have, let's say, 3 lesions in your brain, most medications that are we have available to us now keep the lesions at 3, and it's mostly dealing with the other symptoms that might arise and things like that. So that's one reassurance that we give people, that it's not a lost cause, and right now the treatment is much better than it was previously. The second thing is, and I find this tricky, but also something that has solutions, is fertility and fertility with MS. So patients with MS still need to take their medications, but some medications are safer than others. So it's about the discussions of what needs to happen in that time and the risk balance between that and other stuff. And finally, there's a lot of self-blame that ends up happening in the clinic, like, why didn't I do this? Why didn't I present earlier? And I think it's about centering what we can do now and what needs to be done. And finally, I want to say, sorry, another thing is that depression is part of the syndrome. So, I mean, obviously, being disabled can sometimes give you depression, but sometimes patients have depression because of the MS. And we have to make sure we have to treat it with medications and therapy and all that stuff, but we have to also educate the patient that this is not your fault. This is happening because this disease is affecting the areas that control your mood usually in a normal
Right.
situation. So we will treat that, and we'll try to treat the lesion, and we'll treat that, and you will hopefully get better. So hopefully that decreases the stigma and helps people feel better. But all in all, I can say that despite the risk of complications from medications and side effects, the disease has become much better to manage than it was even
Right.
10 years ago.
That is good to hear that we're getting better with the years. If you don't mind me touching a few conditions where people usually misunderstand them as autoimmune disease. So maybe they're not, but they think it is. And hopefully you can help us today identify those. Things like Raynaud's disease, what it is and why it happens. Can you tell us from your neurological point of view?
Raynaud's syndrome is not a neurological disease. It's a
Okay.
disease that happens, but it's an immune disease nonetheless. It's not an, by the way, so going back to multiple sclerosis, we are not sure necessarily that MS is necessarily an autoimmune disease. Most people think it is, but we think there might be a trigger, like a virus or something like that.
Oh, okay.
But we're not sure yet. Okay, so it is an immune disease, but not necessarily autoimmune. Now, going next step ahead, Raynaud is a description of when your fingers go blue and then red and then, sorry, white and then blue and then red. And that can sometimes happen just because of temperature changes, or it can happen because your blood is attacking the vessels in your fingers and it tends to reverse. And by itself, it's called Raynaud's phenomenon, and it can become syndrome if it's associated with other systems or other blood tests that are positive. And there are treatments just to the symptom itself. You don't always have to treat the thing. You like treat it with prednisolone or systemic medications. You just need to warm the fingers, for example. But
Right.
sometimes you have to give medications or treat people differently. Yeah.
But is it an autoimmune disease?
It can be part of a autoimmune disease. By itself, it's just a description of a symptom.
Right. Interesting. Autoimmune diseases often involve long diagnostic journeys. Now, you did mention a lot of some of the emotional or psychological challenges that patients typically face while searching for answers. How do you, as a specialist, help in those psychological changes?
Yeah, I think there's a couple steps to this. The main step first is trying to, as best as I can, and I mean, not everybody's going to like the way I do things, or everybody is going to like every doctor's way of doing things, is to try and make patients comfortable, to try and make them feel like no question is a dumb question, and have them ask a lot of questions, and have them run at me with their Googling and Wikipediaing and AIing. By the way, I'm fully against AI unless
Okay,
in very limited circumstances.
fair enough.
But I won't delve into that. But because I think the cost that it's costing us is making it much harder for humanity to live than the benefit that we're getting from it. But getting back to the point,
Yes.
um, making the patients feel comfortable is definitely part of the journey. Setting the expectations right initially, giving them best and worst case scenarios is helpful. But then the second part is the patient themselves and their level of resilience and things like that. So some patients take the disease and they're very good with it and they do the right stuff. And even when bad things happen, they have a good mentality about it. And some patients are not. And it's about working on that. And then finally, it's about referring to the right practitioners who might be helpful. So I would say the third part of what I can do as a physician is referring a psychologist, psychiatrist, if that is helpful, or even just counselor, or looking at what is their support network and working around that. So there's a lot of programs with MS that can, link people and certain activities to help them sort of get things better. And managing the symptoms around MS, like I mentioned, the pain syndrome, the bladder issues, even depression with tablets as well, is helpful to help a patient on their journey to be able to have a better situation. Because if I treat the MS and there's no new lesions, but they have pain all the time, they're going to be more sad and as a result,
Yes.
more likely to be depressed as opposed to when their pain is better.
More comfortable body, better mood, if we can say that.
Mm.
Of course. Interesting. All right. Now, you work with patients from a wide range of multicultural backgrounds. As we knew before, you speak 5 languages. So how do language, culture, or stigma influence whether someone seeks help early or not?
Definitely. I mean, I think obviously there's some cultures that tend to, um, be less skeptical of physicians and things like that. Some of it's for historical reasons. But what
Right.
I would say is, in general, people will feel more comfortable with people who speak their own language or at least understand their culture. That's one. And two, I would say that older patients in all cultures, these are all gross generalizations, but are from personal experience. Older patients tend to just like listen to what I'm saying and just do it, which is the sort of older paternalistic type medicine. But the new medicine is about shared decision making. We give the
Right.
patient the options, and in MS specifically, it is a very important way because there's a lot of medications that can have different positives and negatives, and um, as a result, you will have to have the decision with the patient as well.
Right.
So I think, try to understand the patient's culture as much as possible. Speak to people at their age and try to understand their lived experience. So I think from understanding a patient's lived experience, for example, LGBTQ patients, I don't know people in my vicinity who are that, but if you are a patient, you definitely have a different experience from other patients that are straight, cis, male, female, binary. So trying to understand that is always very important. So developing empathy is helpful to be able to get people to present more, to tell you more information so you can help them better and get to fix things.
Amazing. That is great to hear, Doctor. I would like to know if you know any new therapies or clinical trials are emerging into our world in Australia that can help people with autoimmune patients.
Yeah, so immune disorders are Australia is actually a pioneer and a leader, and the reason for that is actually because we have good access on our PBS to most medications, and most patients don't have to jump through most hoops to get the medications. So
Right.
you can just get them basically when the doctor says that. So that's great. But on top of that, there's a lot of interest in treating patients because the incidence of autoimmune diseases in Australia is higher than other places, specifically MS as well. And I would say that as a result, it's very important. So with that caveat, now I told you that in MS and in a lot of immune diseases, what we are at the moment is we can make sure that lesions in the brain stay where they are, and you stay what if you, let's say you have right arm weakness, you just have right arm weakness and that's it, and you don't develop further. The holy grail, the next step, is renervation of the areas that have been damaged. And there are
Okay.
medications that are called tyrosine kinase inhibitors. That is a group of medications in the immune system that is felt to reverse the syndrome.
Wow.
And there's a lot of studies on it, and some studies are starting to work, but we are not fully sure. But the idea is even outside of immune disorders, renervation can potentially be a way for patients to get better. The other thing that's been here for a while but is becoming better is some patients who have immune diseases that don't respond at all to any treatments and people get really worse, is bone marrow transplants. And some
Mhm.
patients get bone marrow transplants for refractory, what we call refractory, so has not been responsive to any treatment, immune disorders. And we are doing a lot of research around optimizing that and
Wow.
understanding where that is. And the third thing that was a bit of a splash, but sort of has become a bit quiet, is we think there's a correlation between MS and EBV, which is the syndrome that people get from exchanging saliva in their teenagehood, which usually just stays in your gland, but the correlation is there. And the
Okay.
idea is EBV is very hard to vaccinate against, but there is a feeling that if we vaccinate against EBV and we're successful, that will probably decrease the risk of MS specifically.
Wow.
And
Interesting.
and then finally, in autoimmune disorders, there's that are encephalitis, so brain inflammation secondary to autoimmune disease, which can sometimes give you seizures, get you in a coma, or give you a bit of mental fog. There's more understanding of how the immune system works there, and there's more specific medications that are being worked on regarding that. So the field is very active and is doing very
Lovely.
well in terms of developing.
It's great to hear that, and it's great to hear that's all happening here in Australia. Now, Dr. said towards the end of my show, I always love to do some myth busting. So, if you don't mind, let's bust some myths. I'm going to give you a few statements about autoimmune diseases. Tell us if it's true or false, and maybe a little why. Now, autoimmune diseases only
Okay.
affect older people. What's your say about that?
False. So, like I mentioned, the big group is middle-aged, young to middle-aged, so 25 to 45-year-old females. It's contentious calling young or middle-aged.
Right.
But again, the disease can happen in any stage. For example, when we talked about rheumatoid arthritis, there's a juvenile form which happens in children. So,
Right.
false. It can happen at any age, but if we want to play odds, females in their 20s, 30s, and 40s is the highest uh, group.
So my second statement for you is stress alone can cause an autoimmune disease.
Okay, so I would say false, despite the new studies. Stress is definitely important to make any disease worse, but causing means that if we give a person who has medium risk of developing immune disorders and we give him stress and then or we take away stress, then they're going to get better or worse, and that's very hard to prove. We know that it modulates the immune system. The immune system is actually sleepier, but that doesn't have a direct line that we say this can cause that. It's definitely a risk factor, it makes things worse, but it's not a cause.
Awesome. My third statement to you would be if your tests come back normal, you definitely don't have an autoimmune condition.
Big false. So I think even doctors fall for this, that they rely on the tests. These
Right.
are syndromes. The immune tests that we have test a specific thing, which can be wrong or we can pick it in the wrong way. So, for example, an immune disorder that happens is called temporal arteritis, in which you get an inflammation in the artery next to the eye, and sometimes people biopsy the vessel next to the eye, and it
Yeah.
shows that it's a normal vessel, but that disease gives you what's called skip lesions. So they jump in between, and there's areas where it's normal. So then you're stuck deciding for yourself that this, do we just rely on the tests or do we rely on the situation? So what I would say is clinical history and clinical examination are king. The blood tests and the investigations are only to help patients have a higher likelihood or lower likelihood of the disease being there. But yes, so you can have normal tests and have an autoimmune disease at the same time.
Interesting. My next statement to you would be an autoimmune disease is always hereditary. So if my parents have it, I'm definitely having it.
No. So false as well. So there is when you talk about hereditary and autoimmune disease, even if if they have autosomal dominant immune diseases, which can rarely happen, um, these can give you a 50% risk. But the second thing is what we understand, there's genes called the HLA system, which decides on how our immune system is set up. And there's 3 times 7. So there's different permutations of these immune types. Basically, based on what this machinery is, you have a higher risk of developing certain diseases and a lower risk of developing others. So, for example, there's immune diseases that can affect the lower back, the eyes, and some joints called HLA-B27. So that's a specific type of HLA. So
Okay.
what I'm saying is you inherit that risk, which is not 100%, and it can sometimes you will not have the disease despite there's something that's else. The other thing I want to say is sometimes you inherit a cluster of diseases. So there's a cluster of diseases that tends to happen that gets together. So alopecia, so autoimmune loss of areas of hair, and lupus and others, they're all cluster in one. And there's another one with rheumatoid arthritis, inflammatory bowel disease, and others that tend to cluster together. So you don't necessarily have the same disease as your parents if you have that cluster as a result. So it's not a one-to-one relation is what I'm trying to say.
Okay, great. My last statement for today, MS always leads to severe disability.
No, there's a lot of mild forms by itself, and our treatments are getting better. So I think that we are going to, in most cases, actually, newly diagnosed people don't have bad disability. They have a bit of disability. We measure that with something called an MRS scale or EDMS. So the disability scale for multiple sclerosis, and it's 1 out of 100, and most people stay at 20 or 30, so very low.
Lovely. Great to hear. Dr. Serge, that was our show for today. I really want to thank you so much for joining us and helping us really clarify one of the fastest growing health challenges in Australia, which is an autoimmune diseases or autoimmune medicine. So thank you again for being with us today.
Thank you so much. It wasn't fully my area of expertise, but I tried my best, and hopefully I've answered most questions.
You did really well. Thank you so much. Before you go, let's just address our audience. If you or a loved one is experiencing unexplained neurological symptoms, from numbness and weakness to persistent vision problems or unusual inflammation, just like Dr. Serge mentioned today, please speak to your doctor early, because early diagnosis can change everything. This was Scientifically Speaking with Christine on Oz Arab Media. Until next time.